Thank you very much, everybody, and welcome to our evidence-based medicine presentation as part of the Base Station Physician Committee series. And we are thrilled today to have our very own county medical examiner, Dr. Steve Kampman, and he'll be speaking to us on COVID-19 and the medical examiner. Thank you.
Well, thanks for having me. And if you're worried about time, don't. I was aiming for 30 minutes. So I see I got 60. So I'll try to tell stories and speak slowly. Thanks for having me. No, I'm actually glad to speak about COVID and the medical examiner because there's been some misunderstandings and some, some unusual information out there regarding COVID deaths, how we count them, how they're counted, and what goes on a death certificate and that kind of thing. So I'm glad to speak about that. One more adjustment here. Okay.
That one person conspiracy, so weird.
I lost the chat function, so I don't see that right now. If anybody's chatting in to ask something. So anyway, so I'm going to talk about how the medical examiner becomes involved with COVID deaths. Who do we test? And then about death certification, what goes on a death certificate. And then some of the autopsy findings for the COVID deaths we've seen. And then a bit about our department's role in handling surges of death. So the medical examiner is required to look into the cause and manner of death according to two laws in California, Health and Safety Code Section 102850 and Government Code Section 27491. They say, first the Health and Safety Code, that basically anybody who knows of a death that meets one of these conditions, they should notify the medical examiner or coroner. That is, one is without medical attendance, and that means they don't have a doctor at all. Not that their doctor wasn't sitting with them, but they have no doctor. The next is if the doctor wasn't sitting with them. So if they haven't seen their doctor in 20 days of death. And I'll talk about that again in a little while. Next is if a doctor is unable to state the cause of death, and that sometimes works out to is unwilling to state the cause of death, and that's okay too. Anytime anything other than something natural contributes to the death. So if a suicidal injury or overdose is suspected, any other kind of injury or unnatural condition that might contribute to the death, or if the death is thought to result from the criminal act of someone else. So that's Health and Safety Code. The Government Code says those things and some more, like deaths, natural deaths, known or suspected to be the result of a contagious disease constituting a public health hazard, which would be COVID. So COVID deaths, anytime someone dies with COVID, we're notified of those deaths. But there is part of the Government Code, the next paragraph down, that says if it's a natural death and there's someone that has knowledge of the death that can certify the death, then we can have that other person certify the death. It's what we call waive jurisdiction. So it's our death because the person probably had a contagious disease that's a public health hazard, but we're not going to investigate further. So we take their name and number. It actually takes about 20 minutes to get all the information when we waive a case over the phone, usually from a hospital, and make sure that the death is counted. Just to carry on, deaths that result from an occupational injury or disease, and a death in a state mental hospital, which we don't have too many in the state anymore. But it goes back to when those hospitals were dangerous places for patients to be in. And so the coroner or medical examiner would review all the deaths there just to make sure they weren't injured. We actually have an arrangement with the Edgemoor Geriatric Facility here in town, basically for quality control for the same kind of thing. If someone dies there, we review the death. Even if we don't do an autopsy, we'll at least check the outside of the body. And review their medical history and certify the death. Again, anytime something's caused by someone else in a criminal act, and then the catch-all at the bottom, that's my favorite one. Anytime someone thinks they should call, they should call. So basically that's anytime a death is sudden or unexpected, results from something other than natural. That's basically it.
And Dr. Campman actually goes out to the scene for these deaths because I ran into him one day when we had a murder right outside our Grantville building.
Yeah, right down the street from one of my favorite restaurants too. So, yeah. Just more about how we're involved and just some perspective about that. So I haven't finished all the numbers for 2021 yet. So 2020, there were more than 25,000 deaths registered in San Diego County. We investigated just over 3,300 of those. We only find out on an average year about half of the deaths that occur in the county. The other half fully straight away, their doctors sign their death certificates. The half we do find out about, our investigators review them, see if they meet one of those statutory conditions there. And then if sometimes we'll be able to waive jurisdiction, a lot of the time actually, and their doctor will sign the death certificate. So it's that last little bit of the 25,000 in 2020 that we saw. And most of the people we bring in for examination, a few years ago, we started a practice of if someone, especially an elderly person, dies from complications of a simple fall, so they fall and have a subdural hemorrhage or a hip fracture, and then die shortly thereafter, then if the injuries are well documented by CT or X-ray, and they die while still in a medical facility, so we know they're taken care of, they're attended, then we will still have jurisdiction, still complete the death certificate, an investigation and a death certificate, but we won't transport the body here just to look at the outside of their body. Again, the majority of the death certificates in the county are signed by the person's own doctor or a doctor at the hospital. And then again, I talked about waiving jurisdiction a bit ago. So when there's a COVID death, how is it that we're involved? If they're natural deaths and someone calls and reports the death and everything checks out, everything's good, and their doctor can sign their death certificate. We see COVID deaths when they die in an emergency room. For a while, the kind of the typical story was they were sick in Mexico, had a cough and fever, and came up and died in the emergency room in Chula Vista. So that was a fair number of the COVID deaths we saw. Then there are the cases that we find that I hate to say stumble upon them because that makes us seem like we don't have a brain. But so when we do find a few people at home, sometimes we're given the history that they were sick lately, and we find through autopsy that that they're sick. They have ARDS, and we'll make the diagnosis. In the last month or so, we've had several stories where someone had a home COVID test and tested positive and had continued fever and cough and trouble breathing and then died. So we'll have those people too. And we repeat, we do a COVID test in those cases too, just to make sure. And then we've had people that they died in a hospital with care of COVID, and their family pays the county to do an autopsy. It's part of the government code allows for, if an autopsy is not required for the government's purposes, but a family wants one, they can compel us to do one, but at their expense. So they'll reimburse the county for the procedure. So that's basically what we see.
To the tune of $13,000.
No, it's $3,930. So I wish it were 13,000 because maybe fewer people would use that then, because we actually right now do not need extra autopsies. So, when we review a case and we see that somebody, it's very clear they died of their COVID, and their family just, they say for their peace of mind, wants it. I say, okay, the law allows for that, but now I could get COVID from them, and so could my assistant, and so could the rest of our staff with an unnecessary exposure. Anyway, but we do those autopsies too. Yeah, so the cost for an autopsy is a break-even cost for the county, so there's no profit. And in fact, usually the cost was figured some years ago, and it was based on an average autopsy, but usually family requested autopsies are more than average because there are a lot of hospital records to look at and medical problems to look at that we wouldn't normally see. So anyway, so that's who we would see. So who do we test, or who did we test? Early on, so in the spring of 2020, we started, our investigators started asking everyone, every hospital, every police officer, every family that called to report a death, had they been to China? Did they have any contact with people who went to China? So early on it was like that. And then did they have a dry cough and a fever, and then travel history? And then the symptoms started increasing. I remember speaking with Dr. Koenig about when the loss of taste and smell became, very well known early on. I was actually putting, a smelly oil under my lip every morning to make sure, or under my nose, so I could smell it. Make sure I smelled it every day to make sure I was still okay, because it was such a, at that time that symptom was such a strong, it was really good indicator at that time. So early on, it was that travel and then symptoms. And then as the number of symptoms, known symptoms increased, then we added those. So there was more of a questionnaire of the people who were reporting a death. And then when it became more prevalent, we dropped off. You had to travel somewhere, or know someone who traveled somewhere, or have contact with someone that traveled somewhere, and just went with the signs and symptoms. And then when it was even more prevalent, when we came across someone that, say they were just dead at home, everything pointed to a natural death, they had plenty of natural disease to account for their death, but we didn't know how they were in the last couple of weeks. So they could very well have been sick. So we added those people on to people who are getting tested.
Dr. Chairman, we have a question for you
Okay.
in the chat from Dr. Scott.
Okay.
How many times is there a surprise, unexpected cause when family requests an autopsy on a patient that died in the hospital?
So far, it's pretty, I can't remember a surprise at all. I can't remember a surprise in a hospitalized patient of a surprise cause of death. So
how frequently do you get requests like that?
2 or 3 a month these days. Yep.
Okay, thank you.
Yep. Now we test anybody who has a cough or a fever, or any kind of illness, basically, or their family said they weren't feeling well lately, and it looks to be a natural death. And I'll just throw in, we have a kind of a running spreadsheet. I haven't looked at it quite lately, but about a month ago, we had tested 685 decedents and 96 were positive. So we had about a 14% positive rate. Who do we not test? That is, with rare exception, people who we know a cause of death, like there was a gunshot wound of their head and they died right with that, or they were in a car crash. I think one of our first COVID exposures that we knew about was a man that he and another guy were in a truck on the freeway, and the brakes didn't work. So they decided just to ditch out of the truck when it was still going. And one guy did okay, and the other guy made it to the hospital, with blunt injuries. But in, getting ready to, while being assessed there, he was found to be positive for COVID. So, but the COVID had nothing to do with his death. It was in his nose, but he died of his injuries. We wouldn't normally have tested him, except we knew he was positive from the hospital. If somebody commits suicide, then, and we have clear evidence of that, then we also won't test them. Early in the pandemic, there was at least one question: should we test everyone for, surveillance? And we did look at that, and the final determination was no, that's outside of the coroner or medical examiner's mandate of determining cause and manner of death. We could do it if either the governor or the health officer ordered us to do it, but just testing everyone for interest or group surveillance epidemiology is actually outside of what we're supposed to do and should do. So we could do that if there was an order, though.
Another question for you.
Okay. Yep.
Would you then, at this point, with the prevalence being so high, maintain airborne precautions for your staff in terms of preventing transmission? In other words, assume everybody may have COVID and take the same precautions since you're not testing everyone?
Right. So we right now, if we know or reasonably suspect somebody has COVID, then we do wear different respirators. But if for most people, we wear surgical masks. We've had, unless of course there's some reason to suspect that, we've had, our death scene investigators at, I think it was like last week or the week before, we had just over 24% out with COVID. But among pathologists, only one was sick for a little while, a long time ago, and same with our autopsy staff. So we're doing pretty well in that way.
And another question from the chat: does that mean that suicide from depression are not being called COVID related?
Yes, it means that. Yep.
Thank you.
I'll talk about that in a little bit. Oh, so we're on a new topic now, death certification. So there's an art kind of to cause of death statements or completing a death certificate. And this, I feel bad sometimes for the CDC nosologists and classifiers who have to sort through what goes on a death certificate for their statistics. So here's one that I just pulled out of the, from a long time ago. The way the death certificate works, this is just an example of one that's, it's a natural death, so we don't need to be involved, but the death certificate doesn't quite fly right. So deep vein thrombosis isn't caused by hypertension. Hypertension isn't caused by colon cancer, and colon cancer isn't caused by prostate cancer. So that's the way it's written, is that prostate cancer is the underlying cause of death. Prostate cancer can be a risk factor for deep vein thrombosis, though, so can colon cancer. But the way it's written here doesn't fly. So there is some thought that should go into certifying a death. There are two parts on a death certificate called Part 1 and Part 2. Part 1 is kind of like the main section that should have the underlying cause of death or the proximate cause of death, and then sometimes can have some more immediate causes of death or almost mechanisms of death too. And I'll show you some of that. And then Part 2 is a place for other significant conditions contributing to death, but not directly contributing to the cause in Part 1. So I'll go into that. So the underlying cause or the proximate cause is basically that injury or illness that resulted in death, the underlying injury or illness that resulted in death. So that which in a natural and continuous sequence, unbroken by any intervening cause produces the death. And it has to be a specific disease or injury. So cardiopulmonary arrest is a mechanism or an immediate cause of death, but it's not an underlying or proximate cause of death. So we have to say what caused the cardiorespiratory arrest. Immediate causes of death are those complications of the underlying cause of death. And you can also think of it as the mechanism by which the underlying cause of death resulted in the death. So things like, ARDS or sepsis or congestive heart failure, multi-organ system failure syndrome. Those are all things people die of, causes of death, but those are more immediate causes of death. We got to figure out why they died of those things. So what caused the sepsis or what led to the ARDS? That's what we have to do. So the immediate causes of death usually aren't specific to a particular disease. So like pneumonia. People can die with pneumonia, but is it from aspirating their soup because they didn't swallow well because they had Parkinson's disease? So Parkinson's disease is the underlying cause of death. Or did they overdose with fentanyl and lie there for a while and breathe in some spit and barf and get aspiration pneumonia? Same thing. Anyway, so there's the underlying cause can have some some immediate causes, but basically all you have to have on the death certificate is the underlying cause. So here's a death certificate from the community. Cause of death due to acute myocardial infarction due to coronary atherosclerosis. So fine. So cardiopulmonary arrest is descriptive, but a lot of us have that, so it's not very specific. Acute MI, also good. But what caused all that was atherosclerosis. So that'll be the underlying cause of death. And in fact, you don't actually have to even write cardiopulmonary arrest due to acute myocardial infarction. You can just write coronary atherosclerosis or atherosclerotic cardiovascular disease and not have 3 lines on there. Here's another one just from the community from some years ago. Cardiovascular collapse. It sounds bad. I don't know what it is. I mean, it sounds bad, but it's not very specific. Due to hepatic encephalopathy, I'm getting more specific. Due to cirrhosis of the liver, getting even more specific. And due to alcohol abuse or chronic alcohol abuse. Again, that death could also be certified just as complications of chronic alcohol abuse, and that would be fine as well. So here are some examples for death certificates to kind of put COVID in perspective and just talk about certifying deaths. They are made up. So these are not real people, but they're really easy to make up because all of these things have happened over and over again. So here's a 19-year-old man who is in good health. He skateboarded to a party where he drank a quart of vodka to win a bet and then smoked somebody's crushed oxycodone pill. And then shortly after the smoking, he was found unresponsive in the chair. He was resuscitated and got spontaneous circulation back, but then died about 5 hours later. And at the hospital, his urine tox screen was positive for ethanol. His COVID test was also positive at the hospital, and his CT of his head was consistent with just anoxic changes, anoxic encephalopathy. At autopsy, he had some non-specific findings, just generalized visceral congestion, pulmonary edema and congestion, and cerebral swelling. His blood alcohol concentration was 0.48%, and he had 16 nanogram per mil fentanyl, which is a little higher than what we see in a lot of, I hate to say recreational fentanyl users, but non-prescription fentanyl users. And this was also this case was a kind of a pitch to encourage everyone to keep including fentanyl on urines on screens at the hospital. So I think we're up to a little more than 50% of our area hospitals are including fentanyl now, versus only 4 out of the hospitals probably about 2 years ago. So, so there.
Dr. Knappman, I think
Yep.
this is also a good example for the pre-hospital providers to remember our option for leave behind naloxone in cases where patients are still alive and might benefit from that in the future. And did you want to make any comments about the cause of death in this age group, that it's higher for opiate overdoses right now than for COVID in this particular age group?
Oh, for sure. Yeah. Yeah, it is. It is. Right now we have so many deaths and so few pathologists, so many deaths from drugs that we've had to adjust our practices here. And and it's not best practice, but it's actually a necessary practice. It's the only way we can survive. When we see someone who is totally, the circumstances shout drug death. So they're slumped over, we call it the frog slump. So they're often slumped over on their knees with their face down or their bottom up, just slumped over. A rolled up piece of paper, dollar bill, playing card, or a hollowed out, ink pen, any kind of a tube to breathe something through, piece of foil with some brown stuff on it, and a crushed up pill, or any of those combination of things. And they're dead at a death scene and no history of a disease that would account for their death. We get them here, and if we're able to draw urine early in the morning and it's positive for fentanyl and meth or fentanyl and cocaine or something like that, then we'll actually, and we can get a good toxicology specimen like blood, we'll actually not do an autopsy and rely on the toxicology findings, because there are so many people dying every day and so many people with the same circumstances with drugs that we just can't examine everyone every day. In fact, today there were 28 people on the list and there are 3 of us here. So just to give you some numbers there. So yeah, for people in this age group, it'll be drugs and less likely COVID. And in this man's case, he had a positive COVID test, but it didn't contribute to his death. So for his death certificate, it would be, his cause of death would be acute fentanyl and ethanol toxicity and the manner of death accident. So there's, COVID, wouldn't have a role in his death. So it was something he had, but not something that contributed to his death.
Thank you so much for sharing that perspective. I will just
Sure.
add, we've also made free naloxone kits available for emergency departments to give to patients who are being discharged and could benefit from them. So please take advantage of that as well. Thank you.
A little bit different, where COVID does have a bit in the contributing condition. 81-year-old lady with health problems, congestive heart failure from long-standing heart disease, fell at home and broke her hip. She was hospitalized and then had surgical repair of her hip. The surgery itself went okay, but within a week, still hospitalized. Her heart failure exacerbated, and she had more shortness of breath, fever. Oops, I got 2 heart failures in there. And was found to be COVID positive and die. At autopsy, she had, of course, the heart disease we knew about, multifocal coronary artery atherosclerosis. In fact, an old coronary artery bypass graft, left ventricular hypertrophy and biventricular dilatation, hypertensive kidney changes, arterial atherosclerosis, bilateral pneumonia and early ARDS, acute respiratory distress syndrome changes. And of course, she had a recent hip fracture. So putting that all together, her immediate cause of death, there are different ways this death certificate could be written, as long as the information's on there. So her immediate cause of death is, you could say, congestive heart failure due to atherosclerotic and hypertensive cardiovascular disease, or just the heart disease. So atherosclerotic and hypertensive cardiovascular disease, contributing conditions, bronchopneumonia and COVID-19 COVID-19 infection, complicating immobilization following the hip fracture. Of course, her surgeries go on there on the death certificate. And because an unnatural thing contributed to her death, that is her hip fracture, that put her in bed, that set her up for the respiratory disease, the death is classified as an accident rather than natural. So even though the main cause of death is her heart disease, because the hip fracture is on the death certificate, it's classified as an accident. So, would someone count this as a COVID death? They could count it as a COVID death. And because COVID-19 is on her death certificate and it had a reasonable contribution to her cause of death. So it's actually time to talk about two things. So when does COVID-19 go on a death certificate? I think there's one more anecdote or one more story after this, but it goes on a death certificate when it is either a cause or a contributing condition to the death. It doesn't go on a death certificate if someone just was COVID positive. Early on in the pandemic, we had a death out in the community where the doctor insisted on writing COVID-19 on the death certificate, even though the woman did not have COVID-19, didn't have signs or symptoms, and in fact had only negative tests. She was end-stage heart disease with hospice, and she had had some chest pain, and then died. And her doctor wanted to have COVID on the death certificate because he felt that she didn't go to the hospital, even though she was a hospice patient, didn't go to the hospital because she was scared of getting COVID there. Therefore, it should be counted as a COVID death or a collateral COVID death. So, he said it was his right to put it on the death certificate, but the health department didn't think that was the best use of a death certificate. So we had to work with them, So basically I was called to be in a kind of an intermediary there between the health department and the certifying physician, to kind of, say, this is for statistics and we're counting deaths. We're making sure we count appropriately, and this one doesn't count. So yes, it may be that the woman was scared to get some treatment because of getting the COVID at the hospital, but she didn't have COVID and it didn't contribute to her death. In a way, it might have contributed to the circumstances of the death, but not physiologically to why she died. So he ended up settling to write fear of contracting COVID as a contributing condition. And in that way, the health department and the CDC would not count it as a COVID death. Just, it was able to get it on the death certificate. So 67-year-old man with poorly controlled hypertension and diabetes, had fever, loss of taste, diarrhea, and shortness of breath, found to be COVID-19 positive, intubated, developed multi-organ system failure, and died. He had ARDS, changes of both lungs, large heart with left ventricular hypertrophy, histologic findings of acute tubular necrosis, and marked segmental glomerular sclerosis that goes along with diabetes, and anasarca. So for him, cause of death, respiratory failure due to COVID-19, contributing conditions, diabetes, and hypertension, and a natural manner of death. No, one more thing. So there is from FEMA, I'm pretty sure it's $9,600 that the federal government will reimburse for funeral expenses if COVID-19 is on the death certificate. So, if we see it and we know it's part of the cause of death, it'll go on the death certificate. But if it's not, and just someone was positive, then it's not going to go on the death certificate. So there was a case where a family called and said they had spoken with a state assembly person. Hello? Anyway, state assembly person who told them to call us because we could add COVID-19 onto the death certificate, which of course we can do, but we have to see that it is indeed a factor. So I looked up the case, and it was someone we saw, And it was a man that was found dead in a hotel. And there was a CD case, CD, music thing that I guess people used to use, but there was a CD music case there that had some pink powder on it. And there was the usual stuff, the foil and all that stuff. So he had an autopsy and he had fentanyl and cocaine and no signs of COVID. We did not test him for COVID, but there was no reason to. And I'll show you some lungs that COVID lungs, we call them, that would have prompted us to test if we saw anything like that. So his cause of death was just fentanyl and cocaine toxicity in his manner of death accident. So the reasoning, why they thought it should go on the death certificate and why the state assembly person told them to call us was that he lost his job because of COVID. And because of that, he started using drugs. And because of that, he overdosed. Therefore, it's a COVID death. But again, that's not how it works for death certification. We can't put it on the death certificate. So anyway, that was a true story. Not that the other ones weren't true, but that one was almost word for word true. So there are some references that are handy and easy to use that can help with death certification. The Birth and Death Registration Handbook is from the state of California Public Health Department, is actually online for free. Really long, but has lots of good reading in it. The Medical Cause of Death Manual, published by the College of American Pathologists, is good for writing cause of death statements for natural deaths. And then the book on the right, Cause of Death Statements and Certification of Natural and Unnatural Deaths, is good for writing cause of death statements when there's other than a natural condition, which hospital doctors and community doctors won't have to worry about doing those. They'll just have to do natural death certificates. So here are some references for that. So some autopsy findings in deaths due to COVID. These are what we would call COVID lungs. So if we had no history of somebody having shortness of breath and fever and couldn't taste their breakfast, all that kind of stuff, and we saw these lungs, we would test for COVID. These lungs are very solid and they're firm and big. So instead of weighing 300 or 400 grams, they weigh 1,200 or 1,300 grams. When sectioned, the only thing I regret is that I didn't have a normal lung. I didn't put a normal lung picture here too, but lungs are pretty floppy things, billions of little airbags in there. So that this lung is, stands up and has a flat cut surface, shows that it's a solid thing now. It's a kind of uniform and a bit pale. When they get splotchy, that's usually when there's superimposed pneumonia on them. But this is what a COVID lung looks like. Microscopic. Yeah.
Question, Dr. Campman.
Yeah.
Before COVID, what diseases would you see this appearance that's similar to a COVID lung? Yep.
So, it'd be anything that causes ARDS. So rarely a toxic exposure, sometimes a viral pneumonia, or sometimes bacterial pneumonia with ARDS also, but it's not even, when we had some influenza, the novel influenza some years ago, we saw more just pulmonary edema and congestion and a little bit of ARDS, but not quite so firm like that. So when we see lungs like this, we know it's going to be COVID. On the left, I actually did take a picture of a basically normal lung histology. So the lung on the left is congested. So there's a lot of blood, the capillaries in the alveolar walls there. But you know what? I think this cursor, oops. So the cursor shows, right? Yeah.
Yes, it does.
Okay, so here's an alveolus, or one of the air sacs, alveolus, and in its wall, the capillaries are all congested, and some of the smaller vessels are also congested. But basically, this is a normal lung with spaces where air can come in and carbon dioxide can go out. here's a COVID lung with acute respiratory distress syndrome changes. The main thing we're looking at are these thick, dark pink things called hyaline membranes. So, there's not really a lot of pneumonia here. I'll show you one that does have. So, here are too many white blood cells in an alveolus. So there is some pneumonia, but here's an airspace that's almost clear, almost, nothing there except the alveolar wall here underneath the pink stuff is covered with the hyaline membrane, which then makes gas exchange inefficient and, causes respiratory failure. Here's kind of a close-up of hyaline membranes. So here's the alveolus, here's the alveolar wall, and this darker pink things are the hyaline membranes. They're covering the wall of the alveolus, making, oxygen exchange, not efficient. Here's, as a little more time went on or goes on, it's more organizing. So there are some fibroblasts and macrophages, they're trying to clean things up, but then, they're just occupying the airspaces. And here is even more advanced, where there basically aren't usable airspaces because of hyaline membranes and macrophage, cleanup cells that are, trying to repair but can't. And here is some acute pneumonia, so more of the neutrophils or white blood cells coming to fight and clean up the acute pneumonia. Another cause of death, another reason we see COVID deaths are when people die of pulmonary thromboemboli. So that got figured out, that there was a thrombophilia associated with COVID-19 pretty early on in the pandemic too. So when we saw someone that had no history of respiratory trouble or travel to China or anything like that, no history of anything, and just died suddenly. What's that? Then we do test anybody we see with pulmonary thromboemboli or thrombosis of any kind. Now we test them for COVID, and we found some COVID positive people. So there is enough of a relationship between thrombophilia, blood clots, and COVID that we would list COVID on a death certificate in a person like this. So these are lungs that the pulmonary arteries are just occluded with the thromboemboli. Let's see, I think that's everything. Oh no, surge. So, as part of our role for the community is to help maintain, with the public health, is to absorb some of the deaths when the community became overwhelmed. So we did plan for this, and so far we only used it for a few months, about a year ago. So December last year, we had secured 5 of these 53-foot refrigerated trucks from the state. There was actually a benevolent trucking company that donated 80 of them to the state of California, to the coroners of the state of California. So we got 5 early on. And for a long time, I was, kind of, well, not embarrassed, but, sheepish or, kind of feeling silly because things were going fine. And, maybe we overreacted, but in fact, we needed them. So it was December last, not the one we just had, but the one before, that we ended up using all 5 of the refrigerated trucks. So we lined some with shelves that we got, so we could put about 50 bodies in a truck. And we ended up having just shy of 300 bodies from 16 of the hospitals and some mortuaries in the town that just had no more storage capacity. So we still have all 5. The county has all 5. We still have 2 on site, and the others we've sent away for storage, but we're totally ready and hoping not. So actually, I did expand a little more than I was thinking. So I talked about how we get involved with COVID deaths, even though they're natural deaths. Who do we test? What goes on a death certificate? When someone would be a COVID death, or when COVID would go on a death certificate and when it wouldn't. Some about the main autopsy findings we see, and then a bit about our role in surge management for the county. So does anybody wonder anything else?